Check out the full episode of the Bendy Bodies podcast on your favorite podcast app. Yeah, I'm super excited to talk with you because I know so many people are so frustrated how to get better care, how to work with their internist in a way that, is really helpful for them. And I know that you talk about so many amazing topics on your podcast, Curbsiders. It's such a great show. I know I've learned
Thank
a
you.
lot from listening to it, and I hope people will go check that out. We'll be sure to link your show in the show notes so people can check out your podcast also, because it is really important and you cover so many great things.
Yeah, I appreciate you saying that. And I mean, I think much like your show, we try to make it practical. We try to make it pertinent to, like, our audience has these pain points, so to speak. They're seeing patients with certain complaints. They might not know how to handle it. So we try to get an expert in that can teach us how they would handle it. That way, in primary care, or we have hospital medicine shows too, we can sort of, help people help their patients more. So it's a really great format to do that, which is why I think podcasting works so well for medical professionals.
Yeah, podcasting is, I think, a great way to teach for sure. So, can we start out by talking about what an internist does and what role they might play in the person who has a connective tissue disorder like hypermobile Ehlers-Danlos or hypermobility spectrum disorder? And, oftentimes they're trying to assemble their team, if you will. And I think it would be important for people to understand right off the bat what that means and what kind of a role that person might play.
Yes. Okay. It's a little hard sometimes to, like, explain an internist to people. They're like, "What do you do?" And I usually either say just like, "I'm a primary care doctor." Sometimes I work as a hospitalist, or I might say to them, "Well, if someone's admitted to the hospital, we take care of pretty much anyone who's not on a surgical service. So we can take care of just any host of things: high blood pressure, diabetes, cholesterol, infections, heart failure, kidney failure." Just really a lot of, we're sort of like the undifferentiated physician. And then you can become a kidney doctor, you can become a heart doctor, you can become a lung doctor, all those things from starting as an internist. So it's really you're kind of a generalist, but you see adults, you don't see kids.
Mm-hmm.
And you see pregnant women, but you're not taking care of pregnant women in the hospital the way a family medicine physician would be.
Right. So that's an important distinction between an internist and a family doctor, right? The family doctor will handle all ages, and whereas internists are going to be managing adults.
Yes.
Yeah.
And
Okay.
I should say to your audience, like, in this full disclosure, we have very poor training in hypermobility, Ehlers-Danlos. Like, we've heard of it. We know it's out there. I was talking to my partner on Curbsiders, who has, throughout his career, at some points, he's had actually just ended up with, like, a panel, a lot of patients with hypermobility and pain from that. So he's a little more familiar with it than I have been, but it's something that I think internists should know more about. Like, there's definitely training gaps in, like, when I was going through training, there was no training in addiction medicine. That's actually becoming fixed very rapidly now. A lot of internists are getting, just because there's so many patients that need our help, that we've just sort of by default become comfortable with addiction medicine. And I think, for hypermobility, that's maybe something that internists should become more, or they should become more familiar with that. But your training in med school, I can't remember a single lecture. And then going to national conferences for the past 8-9 years, I don't remember. I know I haven't attended a lecture, and I probably would have if I saw it, because it would be such a unique topic.
So I would love to connect with you offline about that, because I would love to submit a lecture to do at one of those conferences, because that's so important. Like, up to 3% of the population may have hypermobile EDS or HSD. And so this is a huge percentage of people, because I'm sure they're overrepresented actually in your clinics. It's not 3% of the visits. They're probably many, many more than that, because they're having so many different symptoms and problems. So internists definitely need to be as familiar as possible. And what I say all the time is, these patients are coming to your clinic. You probably just don't realize it, and no one else has made that association either. I personally have hypermobile EDS, and I had been to, my physical medicine and rehabilitation doctor. I'd been to multiple orthopedic surgeons. And even if they did measure my joint range of motion and they would say, "Oh, well, it's way higher than normal," they would never say what that could possibly mean, or think, "Okay, well, this person has complaints in other parts of their body. maybe I should refer them to a rheumatologist or whatever, which
Right.
ultimately that's how I got diagnosed. But I do think it's such an important thing for people to recognize, because unlike the myth that there's nothing you can do, there really is a lot that you can do. So the internist, which is why I'm excited to have you here, the internist can really play a very significant role in the care of these patients. And I try to explain to patients all the time, you can't expect the internist to be an expert in this, because they have to be an expert in so many things. They have to know, like you said,
Right.
how to manage high blood pressure and diabetes and, acute things like acute infection or
Sure.
whatever. But having some awareness, I think, would be really important.
I think that's true. And, part of what has made me like do a podcast on internal medicine for the past 9 years is that I just learned that, okay, so many patients, they're waiting to see a specialist, or they just don't have the relationship with a specialist. And when we can really learn the majority of the workup, get them like 80% of the way there for a lot of topics, start the workup, we can interact better with the specialist if we have like just at least a core baseline knowledge of things. I think you can definitely expect that from your internist, or we should aim to get there for this condition, where is someone like myself, like, this has kind of spurred me to start doing more learning on this, when you reached out to me, because like I said, I admitted, it's not something I knew much about. I've heard about it, but it is something that I think we could do a lot better than we are now, because right now we're doing terribly. So, it's like, we could definitely do better.
Yeah, yeah, I agree. I think there's so much room for improvement. And again, it just, I tell people when they say, "Oh my gosh, my doctor didn't know how to pronounce it," or they were looking it up on Google, and I was like, "That's great that they were looking it up on Google." And if they didn't know how to pronounce it, like, that's okay. That doesn't mean that they're not going to be able to help you.
Yeah, absolutely.
So when you are, I guess not just you, but in general, internists that are within the insurance accepting world, how long would you say the average appointment is for a returning patient and for a new patient?
Yeah, it's definitely variable. I can tell you in my experience, for returning patients, it's usually 15 to 20 minutes. And then for new patients, you might have 30, 40, or if you're lucky, you might have an hour, but most patients are like 30 to 40 minutes with a new patient. And the, I think in some clinics, like some family medicine clinics, I've heard them say you have 5 or 10 minutes, and I've had some patients that are physicians even say that, like, they went to their their primary care, and the primary care said, "Okay, you're here for a physical. We can't talk about any acute
Right,
complaints,"
right.
and they sort of limit that visit. Because I've always worked in academic medical centers, you have a little bit less of that pressure to see high volume, so I've always had like the luxury of having a little bit more time with my patients. So like, I think 20 to 40 minutes. In 20 minutes, I can usually do a follow-up if I've done a bunch of preparation ahead of time. And then, if you run a little over, it's okay. And 40 minutes, you can, if you've done your work ahead of time, like whatever you can learn about the patient before they get there, you can do a pretty good visit in 40 minutes and address like a couple acute concerns. And so I think once you start to get down into those like 20 minutes or less, if someone has a bunch of complaints or they have like a big emotional thing to talk about, it's just unrealistic, and the person's not going to feel heard probably leaving that visit.
Yeah, and I've definitely been on the receiving end of that. Like you said, you're coming in for just a general checkup, and you have a pressing concern, and nope, can't talk about it right now. And that's always challenging. So you just brought up about academic medicine. So what are the different types of practices, and why is that important for patients to understand?
So in academic medicine, it probably means, if you're seeing someone who's in academics, it probably means they're spending a lot of their time with trainees, whether they're medical
Mm.
students or medical residents. So they're not going to be in clinic 8 or 9 half days a week. They might only be there for 5 or 6 days, like half day sessions,
Mhm.
and they're going to. So their time is going to be a little bit more fragmented, um, but they might have less of a time pressure. Depending on where they work, they might have less of a time pressure to see that high volume, because they're not expected to be these sort of like workhorses. As sad as it is in medicine, it's like this is my cynical view of how the system largely works, is like, if you're primary care, they want you to see as high volume as possible, as many patients as possible, because you don't get reimbursed a lot per patient, so they just
Right.
want you to see a lot to make a lot of money. And then for surgeons, like, you want to keep all your surgeries booked, max out as many surgeries as possible, as many procedures as possible.
Yep.
If you own the CAT scan machines and MRI machines, keep them running like 24/7. Unfortunately, that's kind of how things are incentivized. And some practices, you can feel that when you're there, that they're just, rushing through things as fast as they can. I like to think that some of the practices I've worked in, because of its academics, they're a little bit sleepier. You get a little bit more time with the patients. It might be frustrating that you can't see like, if you call for a same day visit. I think that's always hard in any practice, but that might be hard. So we do more telemedicine for some of that stuff, just to try to, like, at least have that contact with the patient and make them feel like, even if you can't see them in person that day, you do a telemedicine. So did that answer your question? I mean, I could go on about this stuff forever.
Yeah, no, that's okay. So you're in academic medicine, so you're in an institution where medical students and residents, et cetera, are being trained. So that's
Yes.
different from a private practice where there could be different types of private practice.
Sure.
But like you said, that depending on who's overseeing the clinic, there could be that higher volume type situation.
Yeah.
So I guess I'm thinking, for a patient who's trying to figure out who they should see, are there certain questions that they should ask if they feel like, I'm kind of complicated, or I really want to have more time with my doctor? Are there certain questions that you think they should be asking when they're investigating different doctors that they might want to consider? Yeah.
I think they definitely should ask about the how long that you get for new patient visits and follow-up visits, because if they're 30 minutes for follow-up and 60 minutes for new patient visits, that's better. More time with your physician is better. I think you can ask things about, like, is this a training site? Because sometimes if doctors have trainees following them, they might kind of have a slower schedule and more time to spend with the patient to allow for having that trainee there. And then there's concierge practices. Sometimes they call it direct primary care. Usually that's where you have some sort of a fee that you pay, almost like you can think of it like a retainer, might be $2,500 a year. And that doesn't, that means, so if an internist has a panel of 1,000 patients and each one of them is paying them $2,500 as a retainer, that allows them to only see 10 or 11 people a day. They can spend an hour per patient. They usually guarantee seeing you within 24 hours. Obviously, you have to be privileged enough to be able to afford the retainer, but those practices, like if you're someone who's complicated and you have the means, those are often good to look into because you have a lot more access, and your internist might even follow you. Like if you get hospitalized, they might come visit you in the hospital, which is not a common practice anymore.
Check out the full Bendy Bodies podcast episode on your favorite podcast app.